Jaipur Surgical School is an online initiative that has been initiated by Professor Kapoor, basically for the general surgical trainees from middle as well as low income countries such as Nepal, Sri Lanka, Bangladesh, and other Middle East countries. So, in this series, we have had many lectures since October, every Friday, 3 to 4 p.m. So, continuing with this series, today we have an eminent speaker from SGPJ Lucknow, Dr. Samriti Nam, and to moderate this session, we have Dr. Sapna Jain from Jaipur. So I kindly ask her to introduce the speaker and then moderate the session. Thank you. You have to unmute yourself, Dr. Sapna.
Sorry, I'm so sorry. Hello, I hope I'm audible now.
Yes, you are audible now.
Okay, a very good afternoon to everyone. I'm really thankful to Kapoor sir for giving me this opportunity. And the topic for today's talk is management of solitary thyroid nodule. And to present this, we have Professor Sabaratnam M. He is a professor in endocrine and breast surgery at Sanjay Gandhi Postgraduate Institute in Medical Sciences, Lucknow. And I'm very happy to introduce him because he was my guide and he was my mentor at SGPJ during my MCH training. And he's keen interest in thyroid, parathyroid surgeries, and he's done a lot of research in this field. He has 300 plus articles to his name. With this, I request Sabaratnam sir to start with the talk.
Thank you, Sapna. Thank you, Piyush. And I thank Professor V.K. Kapoor, sir, and for all his initiatives in teaching and training, especially knowledge sharing, actually. We will have a brief half an hour session about management of solitary thyroid nodule. Okay. So, again, like, if at all you have any queries or any questions, I will take that then and there, or you can ask me at the end as well. So solitary thyroid nodule is a very important topic, especially for surgical trainees, because you might get a long case or a short case, and there is always a question in the exam actually. So I'm trying to cover what is most important things in the management of solitary thyroid nodule. So before we go in, like, I will show a brief case, and then we go into the topic per se. So she was Mrs. D, 5-week pregnant lady. Okay. So age 24 years, MBA graduate from Firozabad, and history was given by patient herself. And she had chief complaints of swelling in the right upper neck for 1 year. And she noticed a swelling in the neck after a friend pointed out. Nowadays, in the selfie era, lot of selfie detected thyroid nodules also is there. And initially it was 1 into 1 centimeter, but it has doubled in the last year. And one another swelling was there, which was noticed by the doctor when she consulted for the same. And it was not associated with fever, pain, skin changes over the swelling, no scalp lesion, no history of ulcer in the oral cavity, no dysphagia, cough or hemoptysis, no hoarseness of voice, no compressive symptoms. And we have to ask in this kind of a patient whether symptoms suggestive of hyper or hypothyroidism is there, compressive symptoms. These two are very important. Then no history of flushing, diarrhea or wheeze, which is for medullary thyroid cancer. Any history of chronic drug intake is there or not, and history of symptoms suggestive of distant metastasis. So then past history, because she has a node probably from history with the thyroid swelling. So any bronchial asthma, pulmonary TB, irradiation of the neck in the past, and she took mixed diet, iodized salt, and her sleep, appetite, bowel, bladder habits were normal, non-smoker, non-alcoholic, no substance abuse. Family history was not significant, and she was pregnant, so that I said. And environmental history in thyroid nodules and goiter is very important, whether in the neighborhood like frequent flooding is there or not, that we should ask. And then history of goiters is another thing in the neighborhood. Treatment history, I said, like she consulted local doctor who did an ultrasound and a needle test, and she was told that she has some thyroid cancer. She was referred to us. She was pregnant, and she got her pregnancy terminated. So, and when we examined, she was well built, well nourished, normal performance status, like, and you can see here this thyroid swelling and a neck, probably a nodal swelling, and thyroid was approximately 2 into 2 centimeter, right lateral to midline. Surface was nodular, borders were ill-defined. It moved with deglutition. No overlying skin changes were there. No dilated veins, no scars, no pulsation. Trachea was central on palpation. And here I said, like there was a nodal lymph node swelling approximately 3 into 2 centimeter, level 2 node. Surface was smooth, well defined, no overlying skin changes, no dilated vein, scar, or pulsations actually. And in palpation, we confirm the inspectory findings, and non-tender, well defined, firm nodular swelling arising from the right lobe, and extent was from thyroid cartilage to cricoid and anterior border of sternocleidomastoid to midline. Left lobe and isthmus was not palpable. Bilateral carotids were palpable and normal in position. And the node was 3 into 2 centimeter, right level 2 node. And it was along the upper third of right, 1/3 of sternocleidomastoid. No other lymph node were palpable actually. The percussion only in retrosternal goiters we do advocate. Auscultation in the superior pole in hyperthyroid patients. Otherwise, there is no such role for auscultation also. Only in Graves or in toxic MNG where you auscultate. And sometimes some examiners want this answer that you can auscultate for bronchial breath sounds and make the position of trachea in a huge multinodular goiter. Systemic examination was unremarkable. So this was the summary of this lady already. So the diagnosis is a right, you can say it's a solitary thyroid nodule, euthyroid patient, probably malignant. That's all. And what is the most common malignancy is papillary thyroid carcinoma. And that's what we made a provisional diagnosis. So, like I'm coming to, like we do a TSH and free T4 in this lady. T3 also was done outside. So it was, she was euthyroid, and ultrasound showed a solid hypoechoic multiple punctate lesion in the thyroid actually. So we now, like BI-RADS, use TIRADS. TIRADS 5 is probably a malignant lesion, and FNAC was classically we could see this is a papillary thyroid FNAC. I will come to that also in a few minutes. So, and then from the node, it was termed as metastatic PTC. So this is the FNAC can diagnose PTC with very good accuracy. So, and we do a indirect laryngoscopy. So bilateral cords were symmetrical, and because in papillary thyroid carcinoma, we can get level 6 and level 7 nodes. It's our protocol to do a CT scan of the neck. In the exam, you be very careful. If your institute does CT scan, you can say. Otherwise, because central compartmental lymph nodes are best picked up on CT scan in presence of thyroid. If thyroid is removed, then you can use ultrasound as a modality. But if thyroid is there intact, then central compartment nodes are picked up by CT scan. CT scan also showed like a hypodense, heterogeneously enhancing nodule in the right lobe of thyroid, and lymph nodes it showed. So we did total thyroidectomy, central compartment neck node dissection, and other side also nodes were positive. So right selective lymph node dissection and left selective lymph node dissection. So, and this patient is cured now, almost 1 year, 8 months, like TG, ATG not detectable, no radioiodine, there is no uptake, and she is doing very well. So actually, now we come to this topic. We have seen a sample case. I put it probably a malignant pathology, most commonly about 4% of adult population will suffer from solitary thyroid nodule. Not all nodules need to undergo surgery. And what is a solitary thyroid nodule? Discrete lesion or lesions within thyroid gland, distinct from the surrounding parenchyma on palpation or on imaging. Okay, so this is the definition. And most importantly, it's not a disease by itself. And there are wide manifestation of spectrum of disease it can encompass. Okay, so it can be benign, it can be malignant. In malignancy, most commonly it's papillary thyroid carcinoma, it can be a follicular thyroid carcinoma or a medullary thyroid carcinoma, rarely anaplastic. Okay, and lymphomas. And in benign, mostly it is a colloid nodule or a follicular adenoma or a papillary adenoma. Papillary adenoma, the term is not used now. So you can, or it can be a dominant nodule of a multinodular goiter or thyroiditis. Okay, so these are the causes of a solitary thyroid nodule. So as I said, like, it is one of the commonest endocrinopathies, nodular goiters. Clinically manifest in 4 to 8% of adults. If you do ultrasound imaging in about 100 individuals in your institution, 13 to 67%, depending on the age and iodine sufficiency deficiency, so many percentage, it can vary anywhere between 13 to 67, and autopsy studies have shown more than 50%. It is highly prevalent in endemic iodine deficient areas, and it's more common in females. The STN is a disease of females or ladies, and it's common in elderly. Of all those 100, if you have 100 thyroid nodules, 5 to 10% can be cancers. So that is very important. And how the nodular goiters, the clinical spectrum can be incidental or it can be overt, large, causing pressure symptoms. And most of the times, as I said, it is a solitary in imaging also. But sometimes only that nodule is there, and there are other nodules in the other lobe also, so which are not palpable but can be imaged. So that is known as dominant nodule or dominant nodule of a multinodular goiter. It can be euthyroid, hyperthyroid, very, very rarely hypothyroid. It can be benign and malignant. So this is the clinical spectrum actually of solitary thyroid nodules. So approach to management of nodular goiter involves clinical evaluation, investigative workup, minimal cost effective evaluation. I was going through the 28th edition of Bailey today because I thought it makes sense for me to talk what is given in Bailey, because you people will read either Bailey, Subiston or Schwartz. So actually this word is very important, minimal cost effective evaluation, because there are so many tests coming now. The PET scan, fancy PET scan, gene testing is there in even FNA specimen. The rule in and the rule out tests are there, but those things are like in India still we do not do that molecular analysis at that level. And what is the purpose of doing this test? To identify patients with malignancy. That is the most important thing. Then with hyperthyroidism, because hyperthyroidism per se can cause some physiological disturbances. And even if it is a thyroid cyst, if it is a big one, it's become suddenly enlarged due to hemorrhage and compressive symptoms, then you have to identify those set of patients and triage those patients who need surgery, and rest all will be kept in observation or follow-up. We cannot operate all patients with thyroid nodules, and it's not worth to do it as well. So before we go into the other management aspects, one thing every time, what is thyroid function test and how will you interpret those tests? That is always asked in the exam. And the table given in Bailey and Subiston is little cumbersome to understand actually, because like surgery PG is not interested in like if you give 5 tables. I thought this 9 square test is easy to interpret because it's simple actually. So this is the 9 square game we tell. So you can, it's based on American Association of Clinical Endocrinologists and International Thyroid Society guidelines. So we can play this game for 2 minutes and see. It's easy. It's not very difficult. So we have 9 squares. In the x-axis, you can say thyroid TSH, thyroid stimulating hormone, and in the y-axis, you plot free T4 or T4. I will say preferably free T4. So you can have a low TSH, normal TSH, or a high TSH. You can have a low free T4, normal T4, or a high T4. Only these many possibilities can be there. So in 9 squares are there. Your patient will fit in one of these squares actually. So if both are normal, that is euthyroid patient actually. If TSH is high and free T4 low, that means patient is primary hypothyroid. Patient, because of less of thyroid hormones, TSH is becoming high. And if TSH is low and free T4 is high, that is hyperthyroid, primary hyperthyroid, or Graves, mainly Graves. If both TSH and free T4 are low, that is secondary hypothyroid. If both are high, free T4 also high, TSH is also high, that is secondary hyperthyroid. And then you have low TSH, normal FT4, that is known as subclinical hyperthyroidism. And if you have high TSH, normal free T4, that is subclinical hypothyroidism. And you have normal TSH, low free T4, that is non-thyroidal illness or NTIs. So non-thyroidal illness or NTI, for example, patient with COVID or any other viral infection will have TSH will be normal, but free T4 can be low. That is non-thyroidal illness. And one more non-thyroidal illness can also present as TSH normal, free T4 little bit high. That also non-thyroid illness, or patient who is taking thyroid, like thyroxine or eltroxin can have this. So at least, so this is the 9 squares. I want you to remember only two things. One is euthyroid. I said both are normal. Hypothyroid, you should. TSH high means hypothyroid. TSH low means hyperthyroid. This much, these 3 squares, if you remember at PG level, that is fine. Rest all, you should understand that is subclinical hyperthyroidism, subclinical hypothyroidism. That is most important. And non-thyroidal illness, if you take some samples from patients admitted in surgical ICU, those patients can have either free T4 normal, free T4 high, but TSH normal. That is known as non-thyroidal illness. But most important, hypothyroid, euthyroid, primary hyperthyroid, that will solve your thing, because there are many tables given in many books which are a little bit confusing, but this is very simple if you want to remember. And like again, thyroid hormones, there are many things: free T4, free T3, T3, T4, TSH. Two things you remember and write well in the exam: TSH. Usually second generation or a third generation test is available widely in India and very easy to do, widely available. Normal range is 0.3 to 4 milli international unit per liter. And free T4 range is 0.7 to 2.1 nanogram per DL. Free T3 is not done at all. So that is because of unstable assay. Very few places it will be stable and you'll be able to get a good values. Usually not done. T3, T4, T3, there is an entity called T3 thyrotoxicosis. In that thing, we need to get a T3 done. Otherwise, TSH free T4 is enough. So I said this is one part. Then we have antibodies, which also will come under thyroid function test. So what are those antibodies? TRAB, the word TRAB. TRAB is increased in Graves, and TPO antibodies are increased in thyroiditis. This much at least. One you read other many are there, but two main things. TPO in thyroiditis and TRAB in Graves. That much you remember. Other antibodies are there, which also will come under thyroid function test. And there are some people say that there is a nuclear test also. The technetium scan can be included in the TFT, thyroid function test, if it is asked. But nowadays there is this one. So at least we should understand first investigation in a solitary thyroid nodule. Once it's diagnosed, you need to know whether the patient is euthyroid or hyperthyroid. TSH is the first test to be done. Then if you have the facility, you can do a free T4 also. Okay. So clinical evaluation, like we have to, another most important part of this is most patients are asymptomatic. So we have to identify the risk factors for thyroid cancer and signs of malignancy in the thyroid nodule. So what are the risk factors? In which group? Pediatric group, if you see a thyroid nodule, most commonly it might be a thyroid cancer. And age more than 45 years, it can be a thyroid cancer. I said that thyroid nodules are common in ladies. So if you find a thyroid nodule in a male, then that can more predisposition for thyroid cancer. If you have irradiation for any carcinoma, plus you have a solitary thyroid nodule, then 40% chance you might. And family history of diseases like Cowden's, Gardner's, FAP, and can have thyroid cancer. And FIO and hyperpara, mostly associated MEN2 syndromes, MTC is associated, and size more than 4 centimeter, and prior history of thyroid cancer. These are all some of the risk factors. Nowadays, we do one test which is it is known as PET scan. Pretty expensive test, or positron emission tomography. So PET associated thyroid incidental nodules of thyroid. It goes by acronym PAIN, PAIN. PET associated incidental nodules of thyroid. If PET you do for some other thing, it detects a thyroid nodule, then it can be malignant in up to 70 to 80% of individuals. So that is very important, because all of you nowadays, because PET is done left, right, and center, that is one thing we have to understand. So what are the signs of malignancy in a goiter? Rapid growth. Symptoms of invasion such as hoarseness. Voice was normal, then it becomes hoarse now. Hard consistency, fixity, vocal cord paralysis, enlarged lymph nodes. If all of these are there, then there is 70 to 80% chance of the nodule being malignant. So ultrasound features, what are the I will come to thyroids, but what are the ultrasound features? Hypoechoic nodule, irregular margins, microcalcification, and taller than wide. This is a nodule characteristic. If you have a cystic node on ultrasound, then it is most commonly a papillary thyroid carcinoma. So coming to, I said we have to talk about ultrasound thyroids as well. But thyroid FNAC indicated in any solitary thyroid nodule more than 1 centimeter, dominant nodules in a multinodular goiter. Unless previously it was said that in hyperfunctioning nodules do not need to do an FNAC. The risk of bleeding is there. Nowadays, there is no such thing. You can, now the recent guidelines say we can do in any nodule, even if it is hyperfunctioning, if it is controlled. Then once you do either by a pressure vacuum technique or passive technique, you need to do at least 3 to 4 passes, and immediately the slide is prepared, and then it is looked for the adequacy of sample, which needs to have 6 clusters, with each cluster having more than 10 cells. 6 clusters, each cluster having more than 10 cells. Now there is a thing saying that even if you have 3 clusters with more than 10 cells, it's fine. So the classical teaching, I have put this purposefully because the classical surgical teaching is little different from the latest guidelines. So this is what is most commonly taught. And if the diagnostic accuracy is more than 95%, see, actually, if you have a solid with the cystic component and in large nodules with necrotic tissue, then the diagnostic accuracy might fall down, and then we might need to proceed with the diagnostic lobectomy. So usually FNAC is done by just palpation, and then you blind FNAC, what we call. Nowadays, if you have in your institution ultrasound guidance, then you can do ultrasound guided FNAC, which will have higher accuracy. And initially, most of the societies came out with the guidelines like if it is an impalpable nodule or a posteriorly placed nodule, and like nodes which are rounded with the no hilum, then you do a ultrasound guided FNAC. Now the recent trend, latest trend is to avoid palpation FNAC, and in any nodule, if you have ultrasound guided guidance available, you can do a guided FNA. So recent guidelines are like that. And FNAC, I will have to again come back and show what is benign. See, you have like Bailey has given a different classification. But the most commonly followed classification is the Bethesda classification, where you have 6 categories: non-diagnostic or unsatisfactory, where we have to repeat FNA with ultrasound guidance. If it FNAC Bethesda 2 means benign. So in what does that mean? That means that in this category, if somebody gives that thing, if 100 patients have Bethesda 2 FNA diagnosis, then only 0 to 3% can have risk of malignancy. Then we have Bethesda 3, which is atypia or follicular lesion of undetermined significance, in which the risk of malignancy is 5 to 15%. So in this, we need to repeat or we need to do a diagnostic lobectomy. Follicular neoplasm and follicular lesion, they are different entity. Follicular lesion means less chance of malignant. Neoplasm, if they give, then it is 15 to 30% chance of malignancy is there. We should encourage the patient for surgery. Suspicious of malignancy is 5. Then the risk of malignancy is 60 to 75%. Malignant, if they give Bethesda 6, then it is malignancy, 1% chance of it being wrong and benign. So in this, molecular testing is also there now. So actually, as I said, other diagnostic tests include thyroid CT scans, which have a limited role. We have discussed about vocal cord in that patient also. Vocal cord for medical legal purpose we need to do. Like other imaging like CT scan, MRI, to map the extent of disease, plan your disease, and very important in malignancy, especially if there is an invasion of airway and vessels. PET scan is a functional imaging. Some groups do, especially if you think of anaplastic thyroid carcinoma or a very what you call locally advanced thyroid malignancy. Now we have gene expression classifiers like AFERMA, or what is called the rule-in test and rule-out test, especially in these 2 categories, follicular neoplasm, follicular lesions, to go in the direction of whether we need to do surgery. They are expensive, and as of now, not many institutions in India do that. So these many investigations need to be there. Then you will have a diagnosis, whether it's really a solitary thyroid nodule, whether it's benign or malignant. Then it is hyperthyroid or euthyroid. Hypothyroid very rarely in thyroiditis, where the patient goes through 3 phases. Initially, any patient with thyroiditis will be in thyrotoxic phase, then they will become euthyroid, then hypothyroid. So very, very important. Previously, in olden days, they used to give thyroxine therapy so that they thought that it will suppress and nodules will not form. So, and then for last 25 years, it was not at all in vogue. So then they said no use. Now there is a renewed interest. These are all not needed for this one, but just I'm saying, because if you see somebody starting thyroxine, they say it prevents formation of new nodules. So some groups do give, but two things are there, two woes, whether you need to observe or you need to operate. So observe, we keep the patient on periodic follow-up, usually with the TSH and an ultrasound. Operation, there are, I have put the hemi, subtotal, and total, because the subtotal, nobody nowadays, it's not done. But in your textbooks, Bailey and this one, subtotal is there. I will come to that. But what is hemithyroidectomy? What is total thyroidectomy? Hemithyroidectomy means you remove that diseased lobe on that side, plus the isthmus, pyramidal lobe, and a small cuff of the opposite lobe. And how do you define total thyroidectomy? Complete removal of all visible thyroid tissue. That is total thyroidectomy. And subtotal, you leave a little bit of tissue near the parathyroid and the recurrent laryngeal nerve. Near total, one more term is there, which is like leaving a small bit of tissue near the insertion, posterior capsule near the insertion of the nerve. That is the thing. Usually, many books say lobectomy is the minimum surgery in thyroid. Okay. So, like as I said, like medical management, does it exist? Previously, they used to give levothyroxine. Now again, it has come back after 25 years. Now they say that if at all thyroiditis is associated and the nodule patient doesn't want to undergo surgery, and if there is a single nodule, some nodules might benefit, but usually that's a big, it is not recommended actually. So actually indications for surgery include malignancy, suspicious for malignancy, and then you have FLUS or AUS, that is Bethesda 3, compression or patient having a nodule which is going retrosternally, pulmonary function test changes are there, sleep apnea is there, and other compressive features are there. Then patients with hyperthyroidism, because hyperthyroidism in long run can have effect on the heart as well as the bones, and size more than 4 centimeter, and other patients' preference. Like if whatever you counseled, you did the molecular test, 2 lakh rupee test, that Afirma or whatever test you wanted, molecular level testing also, then you can counsel the patient, no malignant, it is not malignant, but patient says, no, you get it removed for me, then we need to remove that. So concern for malignancy cosmesis, and in very rarely patient is saying, I cannot follow up and come for regular surveillance, remove that. So again, why I am saying this, signs of malignancy in a goiter, if that is asked in the exam, in your viva. So if it is rapid growth, if there is signs of invasion, hard consistency, fixity, vocal cord paralysis, one side, and enlarged lymph nodes, with the enlarged lymph nodes clinically, then it's malignant. So, and before I conclude, we started at 3:31. I was supposed to finish. I took 5 minutes, 4 minutes extra before, like surgery. Now, like previously it was hemithyroidectomy, total thyroidectomy. Now we have the conventional open hemithyroidectomy, conventional total thyroidectomy. The other surgeries being endoscopic surgery, like the endoscopic bilateral breast approach, or Portois, which is transoral approach for benign goiters or malignant goiters. So you have an endoscopic or a laparoscopic approach. You have a robotic approach, rabbit technique or BABA bilateral axillobreast approach is BABA. ABA is axillary breast approach, and transoral or TOTWA approach is there. That can be done endoscopically, laparoscopically, and robotically. And we have open surgery, we have laparoscopic surgery, we have robotic surgery, we have medical treatment in the form of, I said, levothyroxine or thyroxine. And we have other newer modalities of treatment also, like the radio frequency ablation and the microwave ablation. So these many treatment is there, but all patients all STM not need surgery actually. That is very, very important. So, and we have to triage, rule out malignancy, then operate. I took 2 minutes more also. Thank you so much. But I thought that is important because in your exams, these things might come in the recent advances.
Thank you, sir. Thank you so much. It was a very comprehensive and a detailed talk. I'm sure our students can definitely write a main question answer from this very easily. I especially like the 9 square game, sir. It has made very easy. It definitely will make easy for all, I think, MD and MS students to how to interpret the thyroid function test.
Yes.
Sir, I would like to ask one question. Do we count thyroid scan as also a functional thyroid function test? Because that also detects whether the gland is functioning or not.
Thank you, Sapna. Thank you for that. This one also. Like as I said previously, if you read the previous books, even nuclear imaging thyroid scan also was considered as a part of thyroid function test. Now, only indication of thyroid scan is if you have suppressed TSH, as you will do in your practice. So actually, that is why, like I didn't go into that thing. But if traditionally, if they're teaching in their institution, they have to include thyroid scan also in thyroid function test.
Thank you, sir. Thank you so much. Do we have any more questions? I think we do not have any questions.
So actually, Dr. Piyush is there. So
Yeah,
he can ask.
Yeah, he's here,
Yeah,
sir.
I'm here, sir. I think it was excellent talk. And as Dr. Sapna told that 9 square was a very interesting for us also, for as a GI person also, to what to say in our surgical patients. Since there are no more questions in the chat box, so I would just like to conclude the session. I'd like to thank Professor Sabaratnam sir for sparing his valuable time, and Dr. Sapna Jain for moderating this session. And for all the participants, this recording will be available in our YouTube channel for listening offline also at a later date. Thank you. Thank you, sir.
Thank you.
Thank you, Dr. Piyush. Thank you, Sapna. Thank you.
Thank you, sir. Thank you so much.